Welcome, everybody. My name is Louise Ivers. I am the Executive Director of the Center for Global Health, and I'm the Interim Chief of Infectious Diseases at Massachusetts General Hospital. Absolutely delighted to be the moderator for today's session. Thank you for joining us. We've had this absolutely devastating impact of the novel coronavirus around the world over the past year. 92 million confirmed cases, almost 2 million confirmed deaths globally, massive economic impact, disruptions. The United States, where I'm sitting right now, has been amongst the worst affected, thanks to what I would call a total failure of leadership, an epidemic of misinformation, and just an amplification of all of the existing health disparities, many of which are a legacy of 200 years of racism. This has really meant a hugely inequitable burden of the disease. And in the US, Indigenous communities and communities of color have really bared the worst outcomes. But despite all of this bad news in the last year, we do have this new hope, this glimmer of hope in the availability of vaccines. So with vaccines now existing, we need to move very swiftly to delivery. And the question at the forefront of many of our minds and the subject of today's panel is really, how can we ensure equitable access to vaccines? This question is true within our own institution here. It's true in Boston, in our city, in our state. It's true across our country. And it's true as well as we look globally. So I'm absolutely thrilled to introduce this panel today of very esteemed speakers. We're so lucky to have you all. Thank you in advance. I'm going to give a very short introduction to each person. I'll welcome you to review more detail of their bios in our website for the event, and I'll ask Kerry maybe to post that again in the chat for the participants. We have as our first panelist, Ms. Wanda McClain. Wanda is the Vice President of Community Health and Health Equity at Brigham Health in Boston. She's a senior leader who oversees the Center for Community Health and Health Equity at the Brigham and its community health centers and its relationships with 9 affiliated health centers in Boston. And her work is dedicated to helping ensure the Brigham fulfills its strategic commitments to health equity and high quality patient and family-centered care. So welcome, Ms. McClain. Dr. John Nkengasong is currently serving as the director of the Africa Centers for Disease Control and Prevention, which is a specialized technical institution of the African Union. Earlier this year, he was appointed, or actually last year, as one of the WHO Director General's special envoys on COVID-19 preparedness and response. And amongst his many accolades, recently was awarded the Bill and Melinda Gates Foundation's 2020 Global Goalkeeper Award. Dr. Vanessa Kerry is the Associate Director of Partnerships and Global Initiatives at Mass General Global Health. She's a practicing critical care physician at Mass General Hospital, and she's also the co-founder and the CEO of SEED Global Health, an organization that works to close training and care gaps in sub-Saharan Africa through education. So without further ado, I'm going to pass the microphone to Ms. Wanda McClain to get us started with her comments. Thank you so much.
Thank you so much, Louise, and thank you all for joining us this morning. It's my pleasure to talk about some of the work that we have been doing at the Brigham as it relates to the COVID pandemic. What COVID has laid bare and visible, what has been hidden in plain sight, the disproportionate impact of illness and death for people of color and other vulnerable populations in the United States. The disparities have existed in our country in one form or another since our founding more than 400 years ago. And I don't want to spend too much time talking about the disparities, but just in case some of you are not aware of what people of color and Blacks in particular experience here, Black infant mortality, the gap between Blacks and whites in 2018 in the US was wider than in 1850, which is a time period when Blacks were in chattel slavery in the US. So just hold that in your head for a second. Black women in the US have the highest maternal mortality rates. Hispanics have higher rates of obesity compared to non-Hispanic whites. Asians have 35 times more tuberculosis, and Black men in the US have the shortest life expectancy of any population in our country. Blacks and other people of color fare worse than their white counterparts in every age and income level when it comes to societal outcomes, whether they be in healthcare, as I've described, education, economic mobility, rates of incarceration, you name it. Blacks in particular fare far worse. So it was no surprise then that with COVID, unfortunately, that we've seen Black and other ethnic populations have higher, poorer access to testing, higher rates of infection, often between almost 2 times the rate of infection above other populations, higher rates of hospitalization, 4 times for Native Americans, and almost 4 times for Blacks and Hispanics, and higher rates of death, 2.6 times for American Indians, and 2.8 times for Blacks and Latinx. So that's the problem that we're dealing with here. Some of the causes of this are pretty well documented. The underlying health conditions that I described, being exposed on the job. Many of these folks are critical or essential workers. Housing, living in multi-generational housing with lack of ability to isolate. And then, just the daily life of, transportation, or, going to work sick because they're afraid of losing their income and their jobs. And then, of course, systemic racism and bias plays a huge part in this. What was different about COVID is that healthcare leaders, could see with their own eyes the disproportionate impact on these populations of color. And we recognized that equity had to be embedded in everything that we did. And so here at the Brigham and at the Mass General Brigham system, we responded by establishing and standing up the COVID equity and community health response teams at each of our hospitals. What that meant at the Brigham is that we were able to have pop-up sites in 4 neighborhoods that were hotspots in the city of Boston, and we tried to respond to those factors that were contributing to the poorer impact, the disproportionate impact. We tested over 18,000 community residents in these sites. We responded to their social needs by, in particular, food insecurity that has been endemic as a result of job loss and other conditions. And so we provided over 12,000 boxes of food and almost 19,000 hot meals to those who were food insecure. We distributed care kits, masks, hand sanitizers, and other information about how to keep yourself and your family safe to over 20,000 people. And we screened for social determinants of health and to understand whether people needed access to housing resources or whether they were dealing with domestic violence or community violence. And because we were leading into a presidential election, we also registered almost 400 community residents to vote. So we were very comprehensive in our strategy in our community, but we also were focused on our patients. And we saw that, the shift to virtual care was also creating disparities in terms of access, and so stood up and continue to have a virtual care equity committee to solve and problem solve for those populations. We're quite involved in the advocacy for equity in the Massachusetts crisis standards of care, and then for our staff, who, especially our frontline staff, who were not having access to the information they needed. We expanded forums to be able to address any questions and concerns and provide information to them in multiple languages. And we also wanted to make sure that our incident command structure had access to and could see any disparities that were happening within our system. So so we incorporated the collection of race, ethnicity, and language data into the dashboards for our incident commanders. And then we provided advocacy. We felt like we had a responsibility to be the voice of people who had limited voice. And so we advocated around the eviction moratorium. We advocated for concerns of incarcerated populations as it related to COVID. One of the things that was clear is that underlying a lot of the conditions that we were seeing here in Massachusetts and Boston was issues of racism, systemic racism, and that we needed to address, and we need to address the systemic racism that does exist in healthcare and it exists in healthcare settings, and so that we can have an impact on our patients and our employees in our community. So redressing the historic racial injustices has to be an ongoing part of our efforts to improve the health of Blacks and other groups in the US and to gain their trust. And trust is a huge issue. We are witnessing the impact of a legacy of mistrust or distrust when we look at COVID vaccine hesitancy. And during the efforts to include Blacks and other people of color in the COVID vaccine trials, issues of trust came up. When we approached, because we saw this disproportionate impact of COVID on these populations, people, caring and concerned people prioritize these populations for both the clinical trial and for the vaccination. And have been surprised when these populations have said, no, thank you. We have never been in the front of the line, and we don't trust that you have our best interests in mind by putting us first, that we're not being used as guinea pigs. So even with the best of intentions to prioritize people who have been severely impacted by this disease, that legacy of mistrust plays out every day. And so, and that mistrust stems from some awful treatment in our in medicine, the history of bias in medicine and experimentation. For instance, the evil perpetrated by Dr. James Marion Sims, the father of gynecology, who performed abusive and gross medical experimentation on the bodies of enslaved Black women. Everyone has heard of Tuskegee. The community is well aware of that. And so the persistent inequalities and disparities that I already outlined. Also the lack of investment in our communities and lack of trusted messengers for those communities. And then insufficient and sustained community engagement. All of these factors lead to erode trust and will need to be addressed to build trust. I've relearned during this pandemic that saying that I won't try it in French because my French is terrible, but the more things change, the more they stay the same. And so when you think about vaccine hesitancy and racism and violence, that the combination of all of those factors showed up in a smallpox epidemic in the early 1700s. And a newly enslaved man taught Cotton Mather in Boston about inoculation because he had experienced that in his homeland with the smallpox there. And because of racism in our medical community, they could not accept that a Black man and an enslaved man might hold the key to addressing and coming up with a cure. And in fact, the rage of many people over this led to the bombing of Cotton Mather's home. So it's the parallels to today could not be more stark. But as we think about where we are in vaccine hesitancy, I think it's promising that here in the U.S. Now it's improving. About 71%, at least the data that I have, of the public are saying that they will definitely or likely get vaccinated. But what's not so promising is that 25% of Black adults say they will definitely or probably not get vaccinated. And over a third of the Latinx population of adults are saying that the COVID vaccine did not take their needs into account. And here locally, in the Mass Inc. polling survey sponsored by the Museum of Science and conducted with the Mass League of Community Health Centers, found that 28% of whites said they would take the vaccine as soon as possible, compared to 28% of Blacks and 22% of Hispanic Latinx populations. So if we're going to address, though, these issues of hesitancy, these issues of trust, we need to address those barriers that limit trust in our healthcare system and that are impacting the diversity of both the trials and the upcoming vaccination. Here at the Brigham, and in our system, we see differences in vaccination rates between our own employees, those who are Black and those who are white, with whites accepting and getting vaccinated at higher rates. In a global pandemic, it is clear that we are all in this together, and if we are going to reach herd immunity, we have to increase our vaccination rates. So some of the strategies that we're deploying to reach out to our employees are the Q&A sessions for frontline staff to answer their questions in a non-judgmental manner. Local ambassadors who are in a similar role categories and who culturally, linguistically, and can be trusted messengers, and also using our managers who are trusted managers and supervisors to communicate with their teams to get messages out. People have concerns about the side effects of the vaccine, and so being able to answer those are critically important. So I'm going to close just by saying that these issues of mistrust are longstanding, and it will take time to build trust. But in the meantime, we have to move with speed to get those answers to people, to have them feel as comfortable and as informed as possible about the benefits of the vaccination, and they will decide, when it's appropriate for themselves to take the vaccine. So, and then tackling these broader issues that I mentioned in the U.S. society is going to take a much longer term commitment, but the health and well-being of all of us is at stake. And so, collective action is critically important. So I will stop there. Thank you.
Wow, thank you so much for those wonderful and very thought-provoking comments. I'll just mention to our audience, thanks for joining us. If you have questions, we're going to have plenty of time for Q&A. Do use the Q&A function in the webinar, and I'll be moderating the questions once everyone's had their initial comments. So I'll pass now to Dr. Nkengasong. Thank you for joining us.
Thank you again for the opportunity to contribute this panel. I think Wanda has started off extremely well, and I just feel intimidated to go after her extremely brilliant remarks. But let me say a few things before I address the specific questions that I was asked to comment on about my just overall reflections. So first of all is that we are 1 year into this pandemic, and I'm truly amazed by how extremely connected the world is, and what this pandemic has taught us, how extremely vulnerable we are. I mean, and I really keep, and I mean this in my deep reflection, like if this virus was more virulent than it is, they would have wiped all of us away without exception. And lastly, the extreme inequalities and inequities that exist amongst us. And I think Wanda touched on that. The piece on, and they all relate to the vaccine that I was there, the topic of vaccines and access and equity that I was asked to talk about. We are very connected, so it means that clearly that we are not safe. No one is safe anywhere except we are all safe, and that vaccines will be a game changer in this. That we are very vulnerable. That I mean, it's not a question of whether we vaccinate some people and some people are not vaccinated, and of course that we are seeing the inequalities. The second reflection that I have is that for vaccines, it's a framework of thinking that we want to encourage the world to see vaccines as, of course, a potential game changer for this battle. We have to admit that we are at war with this virus, and that it should be seen as a public good. and that clearly that if it's not seen as a public good, then we run a risk of being committing a serious misjudgment. And thirdly is that we have to work with what Dr. King referred to in 1963 as the fierce urgency of now. So we're not dealing with a polio vaccine or a measles vaccine where we think, okay, with time we'll vaccinate slowly and we'll get there. I mean, if we do not really use that fierce urgency of now, then we are in trouble, because in territories where we are, the virus will become endemic and it will really spiral out of control, and the world would never be a safe place. And that is really, for us, from where I sit, tomorrow is today for the vaccines there. But unfortunately, that is not the reality of what we are dealing with. We have no vaccines on the continent. We admire you all watching you on TV, how you have been getting your vaccines, but we can only hope that vaccines will get to the continent. Now, the issue of my third block of reflection is that something has gone wrong in a world where we say the right things in public, what I call public correctness with respect to expression of what we should all do with vaccines. I mean, and then what I call the expression of statements of goodwill. I mean, and then there's a value of that between the expression of statements of goodwill and the public correctness and then the naughtiness that happens on the other side of it. I think clearly that leads me to the whole concept of access and equity. And because of these parameters and the politics, we have to admit that public health, especially for this vaccine, for the vaccines and COVID-19, has really been politicized and at several levels, and which it shouldn't be. Because it fits into the trust factor that Wanda mentioned. But clearly, we have gotten ourselves into a value of that in translating those public expression. I don't know of anyone, any leader, who takes a public podium and doesn't say that we need timely access to vaccines, or doesn't say the right things then, be it I mean, needless to name world leaders there. How the G20 and everybody there, you read those statements, they all say the right thing, but we don't have vaccines. So that has changed our definition of what we mean by timely and equitable access of vaccine, unfortunately. The definition has moved from what it is now looking to be like, well, we'll first of all get some vaccines and even get more than we need, store it for our people, then we can discuss equitable access and timely access to vaccine. Well, there is no point discussing equitable access and timely access if we don't have nothing to discuss. It's like having food on the table and you take all the food away and you store it, and even in excess, then you come back to the dining table and say, let's talk about equitable access to this, to dinner. There's no dinner at the table. So we have no dinner as we speak here as a continent of 1.3 billion people. We are just hoping and continue to do what we do best as a continent, pray that our continent should be safe from that. So that brings me now to the two questions of how is Africa's CDC viewing the global access and allocation of COVID-19 vaccines? What we have stated clearly is that we should be very mindful that we want to be on the right side of history, and that history has a way of documenting itself, that what may seem like normal today will tomorrow be a moral catastrophe for all of us if care is not taken. That the next generation would actually judge us as to whether the morality of what it was that we took these vaccines and immunized certain part of the world, and even actually advance purchase more than what we need. I was watching the news the other day, and I had a commentary. I had a remark which was extremely touching, where some vaccines are being used and actually doses are just thrown away because you open a vial, you use part of it, and you can nobody else is there to take the remaining one. You toss it away. Say, well, you can't be throwing vaccines somewhere else where we really need vaccines on the continent. So I think that definition has changed, and we need to work hard to bring back a proper definition of what we mean by timely access and equitable access to vaccine. Otherwise, we floor the discussion and we run the risk of getting into what I call a moral catastrophe. And this has happened before, and we don't need to let a moral catastrophe occur on the continent of 1.2 billion. Drugs to ARV, antiretroviral therapy, were available in the developing world in 1996. I remember in the conference, the HIV/AIDS conference in Vancouver, that was topical. I mean, we are running into talks with David Holt, Tony Fauci, and others listening to this groundbreaking cocktail of drugs. And fast forward, the death rates decreased dramatically in the developed world, but continue to increase in Africa. And between 1996 to 2006, 12 million Africans died, and I'll qualify by saying needlessly died because of inequity and because of lack of access to life-saving drugs there. We risk finding ourselves in this scenario. There have been much talk about the COVAX facility, and they've said all the right things, the right principles, the right framework of discussion, but we don't have vaccines. And on the continent, we have been told by COVAX that they have secured or are negotiating 1.9 billion doses of vaccines, of which 600 million will come to the continent, but it still will come to the continent. Okay, we had a meeting with COVAX last week or so. We pressed out as a continent, as a task force put together by President Ramaphosa as the chair of the African Union. He said, go out there and ask specific questions and come back to me with 2 answers. When are the vaccines coming and what types of vaccines? We went into that discussion like students. We said, when is the vaccine coming and by how much? We came out of that discussion with no answer. So we are back to where we are. COVID represents and symbolizes an effort for global cooperation, global solidarity. But if the food has been taken off the table already there, then there's not much that COVAX, I mean, even with the best intention of global solidarity and cooperation can do, especially to the poor. So I think we have yesterday announced that we have secured 270 million doses of vaccine for the continent of Africa. That is a good start. It will not allow us to get to 60% of our vaccination targets, but it's something. And then those are parallel efforts to the COVAX facility, because we have a choice of sitting on our arms and waiting for the COVAX vaccines to show up and facing the risk of a rioting on the continent and the political upheaval on the continent. Because as the director of the Africa CDC, I brief the press and we're getting to a point where the population is angry. I mean, you are not answering my question, John. You can't tell me when people will be vaccinated, and you can't tell me about what kind of vaccines we're getting there. So at least we secured the 270 million doses of vaccines, and we'll start distributing across the continent. Just to conclude my reflections, that I would say that the opportunity to build trust, and going back to what Wanda said, is for between member states and both in the Southern Hemisphere and Northern Hemisphere is now. With the concept of the way I started, where I talked of how connected we are, and I talked of how vulnerable we are as a people living on one planet. It would be a catastrophe that COVID becomes endemic in a continent of 1.2 billion people, and a continent that is already struggling with challenges of HIV/AIDS, tuberculosis, malaria, and other rising non-communicable diseases. And on top of that so we begin to deal with an existential crisis then. So I think I'll submit there by saying that the opportunity, I remain hopeful and optimistic that the opportunity for global cooperation, global solidarity, and global coordination is there, and the vaccines have to be that game changer that is looked at fairly across the board. Thank you.
Thank you. Thank you very much. I'm going to turn now to Dr. Kerry for her comments before we open up for Q&A. Please don't hesitate to put your questions in there. I know there are questions, and we'll get to them. Thanks.
So I just want to, good morning, good afternoon, good evening, wherever you may be. I just want to thank everybody for joining, and I want to especially thank the previous participants' comments. I think, hearing about, certainly from Dr. McClain and hearing about what's happening locally, and as well as hearing from Dr. Nkengasong about what's happening internationally. The reality is that the inequities are for vaccine distribution, for care, for access to health, the themes are really, really similar. And, to hear that we're so small in the world and we're so united and everybody's vulnerable is profoundly true. And I guess, and the question that I've been very much wrestling with is, how do we change that? And I think that from the work that I do, which has been very focused primarily on, and the reason I'm going to end up talking about vaccines a little bit today, is that even though the work that I've been on has been focusing on building healthcare capacity through training and really focusing on helping to build a healthcare workforce in our partner countries in sub-Saharan Africa, the reality is that there has to be a fundamental buy-in that health matters and that our health matters, and that we are going to do everything we can to ensure the health and well-being of every person on this planet. And the context of the COVID vaccine or the COVID pandemic is quite extraordinary, because it fell truly on the heels of this universal declaration by every country in the world that we were going to commit to universal health care. And now we're being asked to actually put our, the American expression, put your money where your mouth is, or to actually walk the walk. And we're not doing that right now in any meaning, in necessarily in the right ways. And so we'll get into this in the discussion, but what I wanted to sort of share a little bit more about is the details of what is happening in vaccine production and distribution, and why does it matter? And so, and how is it maybe addressing some of these equity issues that we're hearing, as well as how is it failing to address those equity issues? And we just heard a little bit about that, but specifically to sort of introduce this idea of COVAX, which you just heard. So COVAX is the third pillar of a COVID-19 tool accelerator. That was sort of an internationally launched program in April of last year with the WHO, the French, and some others to really build out public sector engagement, private sector engagement, academia, pharmaceuticals, everybody to come together around building out the three core pillars of addressing the COVID pandemic, or this is with the idea, which is diagnostic, therapeutics, and vaccines. So this is kind of the stuff, right? When we think the medical countermeasures, obviously this is laced with the anthropology of inequity and access and distribution and power of who gets access to what, but this was the idea. And so COVAX was developed with the WHO and others, really this idea that it would present the world's largest and most diverse portfolio of COVID-19 vaccines, coordinated with the Global Alliance for Vaccine Initiatives, the Vaccine Alliance, CEPI, the WHO. The goal was to help develop a series of vaccines, focus on equitable distribution of the vaccine globally, so achieve, being able to support countries across every socioeconomic and geographic location, but also very importantly to help scale up the manufacturing. Next slide, please. This is just to give a sense of the number of vaccines that are out there. There's actually, anywhere from, depending on who you talk to in the viability, 90 to 150 different vaccine candidates that are through different phases of production. And one of the things that has certainly happened is that vaccine production has been accelerated faster than we've sort of ever seen in history. And in part, some of the technology obviously was already there, but this was also massive investments of money to help create sort of a risk reduction. Next slide. Because when pharmaceutical companies and others begin to develop vaccines, they need to have some of the risk removed, because if they're going to financially invest in having vaccines be produced, they need to have some sort of system to be able to afford it. So COVAX, when it was launched, was really an attempt to have all participating countries who bought into COVAX to have equal access to the vaccines that were produced. So regardless of income level of those countries, you would buy into COVAX, or you'd participate in COVAX if you couldn't buy in, but you'd sort of sign up with this idea that you would be a part of this coalition. And as a result, when these vaccines that were part of the COVAX were produced, you would have access, therefore, to those vaccines based on your population, based on sort of, and other things to ensure that you received a certain amount of vaccine. The goal of COVAX has been very successful. It has 190 participants who are part of this COVAX coalition. Notably, the United States is not a participant, very actively decided not to, and as well, Russia didn't either, which is another major player that has not participated in COVAX. The goal was to produce 9 billion doses by the end of 2021 and to close these market failures, right? So low-income countries that can't afford to produce their own vaccines become part of a coalition that would be producing the vaccines. And then high-income countries that might be able to buy vaccine or might be able to pay for vaccines, but can't actually manufacture the vaccines themselves, which is obviously a major barrier if you don't have that manufacturing capacity, also therefore have access to vaccines and would be somewhat protected. And so it kind of closes these market failures for those countries that don't have the capability to access vaccines themselves. And they set the ambitious goal of creating 20% of the global population basically being vaccinated by the end of 2021, which is roughly 1.5 to 2 billion people would be vaccinated by the end of 2021. Next slide, please. So as mentioned, the goal here is really to reduce the risk of pharmaceutical companies and the production and the risk of taking a chance on technology, putting in huge amounts of money, firing up your manufacturing capacity to produce the billions that are needed in a short amount of time, the chance that your vaccine would fail. And so by bringing together funding from multiple different countries together to help drive some of these engines, the COVAX has allowed pharmaceutical companies to have a guarantee that they would have the upfront, capital to make these pharmaceutical investments and to be able to do the discovery phase of things and to kind of do the research, run the trials, but it also ensures that there's going to be a market for the vaccine when it's produced, because COVAX says we are going to guarantee you the purchase of 2 billion of these vaccines. So the risk of not making money on the back end was taken away as well. So that was one of the very powerful things that happened here, was creating that collective purchasing power, also helping to create a reduction in price. And so it created an insurance for many different people who were involved in this. And then donors like the Gates Foundation, foreign aid would help fund the vaccine side of things for the low-income countries. Next slide, please. The US took a very different approach. The US said, we are going to opt out of COVAX. It was an entirely political decision. They would, the US issued this well-known statement that we're going to continue to engage our international partners to ensure we defeat this virus, but we will not be constrained by multilateral organizations influenced by the corrupt World Health Organization and China. So the US instead introduced $10 billion into its own vaccine system here in this country to develop, produce, and distribute at least 300 million doses of coronavirus vaccine by January. What ultimately has happened, though, with this sort of divisive approach to vaccine production for the globe is that the United States has actually bought up 3 times the amount of doses that it needs to vaccinate the entire country. It has driven about 6 other countries in the EU and Europe to do the same. And so you actually have about 6 to 7 countries that have bought up probably 50% of the vaccine production around the world. If we have 7.7 billion people in the world that need to be vaccinated, the United States and the UK alone have already bought up 1 billion of those 7 billion needed doses. So we're talking about basically vaccine hoarding. With enough vaccine to vaccinate their own populations anywhere from 3 to 5 times, Canada has got enough vaccine to vaccinate its own population 9 times over. So we have the vaccine hoarding. We also have an issue in that we don't know how we're going to be able to distribute these vaccines because there's fundamentally an infrastructure breakdown in many of these places, not just through building trust into certain populations, as we heard from Dr. McClain about what it means to try to vaccinate vulnerable populations or populations that have, don't have trust over time. But when we, think about what it means to distribute vaccines in parts of sub-Saharan Africa where there is no cold chain yet established necessarily, where there may not have the infrastructure, the roads, or you don't have the healthcare workforce to deliver those vaccines, we are going to be in trouble. Next slide, please. So from a US standpoint, and where this is a mistake when we think about where our global responsibility is, and I want to just speak to the fact that we have this very sort of dichotomous approach to vaccines globally between COVAX, or the US's approach, and one of the things the new administration is going to have to think very seriously about, is that even if we achieve getting the United States vaccinated by the end of 2021, we are going to still find ourselves incredibly vulnerable. We already have multiple variants that we see globally that we are hopeful the vaccine covers, but may not. And at some point, there will be a variant that is not going to be covered necessarily by the vaccines we're deploying here. We also live in an incredibly global economy. Our raw materials come from almost every other country around the world. Our manufacturing capacity is often outsourced to other places around the world. So we are not going to be, even if we are vaccinated as a population, we will not be able to step in, unfortunately, to a world that has caught up or been a part of it. This is also, by the way, it's just the right thing to do, to be engaged in the well-being of other people in the world. But I've learned, unfortunately, with this, oftentimes we have to speak about our own sort of, best interest to help motivate the policy side of things and to get our lawmakers to do the right thing in this case. But the reality is we are only as strong as the weakest health system in our interconnected world. And so as we go forth and we think about what it means to vaccinate our country, we should be thinking about what it means to vaccinate the world and to be a part of this global community, both because it is the right thing to do, but as well as the fact that if we really want to get ourselves up and running and on a path to our well-being and prosperity, we need to be thinking about how we are connected to all. And so we have some very tricky questions that run ahead for us and how we're going to do this and execute. But I will just close by saying, as we think about what it means to produce these vaccines, we need to think very, very seriously about what it means to distribute them and to be able to deliver them safely to the vulnerable populations here at home, as well as around the world. And that is going to require infrastructure and investments in health systems. And the beauty of that is we have the ability to change health outcomes for the long run, not just for COVID, but if we make the investments right and wisely, we can address non-communicable disease, we can address HIV, we can address diarrhea, we can address all the other things that challenge many of these populations. Thank you.
Thank you so much. Thank you all for those very powerful comments and really thought-provoking. We're in this morally reprehensible situation where, and I think Dr. Nkengasong, you said it so well, we have on the podium, everyone says the right thing, or in the announcements, everyone says the right thing, but how can we actually start doing the right thing? And the idea that we here in Massachusetts have only given 33% of the vaccine doses in our hands as of this morning, but there's not vaccine yet available for the continent of Africa, despite the words of the global solidarity. And I think it's such a bad situation that, as you said, also everything that changes, nothing changes. It's the same. We could have really predicted that this is what's going to happen, and yet we hold on to this hope or this optimism. And I think what we'd love to think about with you in this discussion as well is how can we as individuals, we as people on this call who do have some power, but not the power necessarily to totally change, although hopefully with the US administration changing, there will be a change in tone, but will there be a change in action? I don't really know. So we have this challenge that stems from, we don't have vaccines in our hands. We don't have dinner on the table to even start sharing. And then we do have vaccines, and the people who need them the most, actually, based on the epidemiology, are the ones most hesitant, with good reason, because they have no reason to trust the medical system because it has failed them in so many ways. So, Dr. Nkengasong, I'm going to turn to you first. We have a question from Dr. Sarah Suleiman, who's an immunologist here with us in Boston at the Brigham. And she's asking, how could we use success stories from Africa, from the continent, on responding to pandemics, to epidemic diseases like Ebola and others, to try to build on trust in vaccines, assuming, which is an assumption, that we'll get the timely access that you want. One thing that I think is also just such a dissonant is the fact that the press in Europe and North America was so eager to distrust the African epidemiology numbers and just say, oh, there's no way you're not having COVID. There's no way you're not dying. And now, you know, so it's like no part of the dialogue has really been very honest or truthful. But how could we, you know, how could we be actually learning from the experience on the continent about responding to these diseases and trying to tap into that experience, especially around Ebola vaccination, which was a new vaccine, and there was so much success there in delivering that.
So let me, at my weekly briefing today at 11 a.m. at time, I said that I do not subscribe to the thesis that COVID vaccination is a huge problem in Africa. I think we just need to develop a strategy and then use a phased approach in doing that. And we've just developed guidelines, which guidance on how to do that on the continent. And again, back to your, and where is this coming from, this optimism coming from? It's coming from ability over the years to work and address other pandemics and existing ones like HIV, okay, HIV/AIDS, the ability to roll out ARVs. You know, I spent 29 years in the area of HIV/AIDS, and I remember in the early, in my field, the US, I was at that time with the US CDC assigned to in Cote d'Ivoire in 1998 to roll out ARVs. And the discussion was very similar to what we are hearing today. It's not, ARVs are impossible to be rolled out in Africa. People don't even know how to read a clock, so they don't even be able to roll out this ARV. Well, we roll out ARVs, and I mean, so think of it this way. Let's take the most challenging vaccine, the Pfizer vaccine, which is requires a storage of minus at 70. Clearly, if you give me 5 million doses or 10 million doses of Pfizer vaccine, what would I do in Addis Ababa, where I'm located? First of all, I would go set up vaccination stations across Addis Ababa, a city of 10 million people, which is a deep freezer, minus 70 deep freezer, back that up with a generator. The total cost of that would be about $25,000 per unit. Second, I would train a large number of healthcare workers, doctors, and nurses that will be able to understand what the vaccine and how to administer the vaccine. Thirdly, I'll provide an information system that will capture people and then make sure that they come back for their second doses. Fourthly, I'll engage with the community very, very aggressively so that they own the program and they can move people to those vaccination sites and as much as possible. And of course, you make sure that you have your supply chain for the auxiliary, that is the needles, the syringes that you need in piercing people's arms and whatever. Those are the 5 things I would do in Addis Ababa. Okay, if you give me the vaccines, that is what I'm going to do. Then, of course, your phase 2 is that you begin to move into the new vaccine that will buy you time, and then the Johnson & Johnson vaccines, who know what will come out, is a single dose, can be stored at 2 degrees or 4 degrees to whatever, and the AstraZeneca's vaccine, use that in expanding. The way we've couched the story is like, it's all vaccines required an ultra chain cold chain. That is not true. And because of that, countries are just saying, well, we are not ready yet. We don't have this cold chain distribution across. I mean, so in short, the response there will be that move people towards your vaccination points than trying to move vaccines across a country like DRC. Most infections in DRC, I was there 2 weeks ago in DR Congo, in Kinshasa. Okay, so you start with those big cities and you start vaccinating. We were able to use administered Ebola vaccines in North Kivu and in Bandaka. That requires other very similar cold chain requirements, minus 70s and minus 20s and whatever. So I think, I mean, that shouldn't be a problem. This is not vaccination at normal time. This is vaccination at extraordinary times. And the continent needs to see it that way and try to vaccinate its people and get to 60% in 2 years. Otherwise, we are doomed. So we can borrow from the experience from HIV/AIDS on how we did that. We can borrow from the experience of Ebola, how we did that in Congo and Guinea, DRC, and that's the country. And we can borrow from the experience of engaging the community. we just did a study of 15 member states where we asked a series of questions. It was a perception study on vaccine. We wanted to know where the mood was on the continent, and especially that early on in this pandemic, there was a video that went spiral where two French doctors were saying in a discussion, were saying that, okay, let's go to Africa and use them. And so we're very concerned with that. We did a study of 15,000 people from 15 countries in Africa, including DRC, where the long and short is that the acceptance rate of any eventual vaccine range from 60% to 91%. Okay, lowest being in DRC, highest being in Ethiopia. So it doesn't look bad, but it doesn't. We have to look at that lower side of it and say, okay, what do we start doing in DR Congo to make sure that we increase that community trust and willingness to take the vaccines there. So building on community, building on the ability that we are used to fighting this pandemic at large scale, i.e. HIV experience, and building on the fact that the Muyembes of the world are there in DRC ready to be creative and endure and be resilient. I think we should be able to roll out the vaccines on the continent. We have to aim, and shoot. We cannot aim, then we stop. I mean, that would be a catastrophe for all of us.
Thank you for that. I mean, I think actually what many of the countries in Europe and North America need to be learning from the African experience, or in the case of where I've worked for a long time in Haiti, where there is just very strong delivery of vaccines, like the logistics capacity, the know-how in the communities, the community health workers and others. And I wonder if I turn to Wanda just to ask you about your thoughts on this too, in terms of in Boston, in delivering vaccine out to communities, how we could try to encourage our own leaders in our institutions here to listen out to expertise from other places where vaccine delivery has been very successful en masse in the past. I wonder if you're thinking of any lessons or drawing anything from what John's been saying.
No, thank you. And thank you, John. I think exactly what you said, there are so many similarities between what you have been successful in doing on the continent for Ebola or for HIV, and what we can learn here. And, what we know is, vaccination isn't new. This is a novel vaccine, but we know how to vaccinate people. And I think even in this country, there have been large successes with getting people vaccinated when we have the will. And I think, Louise, you talked about that, and as did others, about the lack of political will and leadership around this that has really hampered our efforts. And so, I am very hopeful. Number one, that with a change in administration, the messages will be very different. When we looked at what's really surprising or not surprising to me is when you look at populations with large vaccine hesitancy here in Massachusetts and nationally, Republicans are high on that list of people who say they will not be vaccinated. So this tells you that, messages matter. And so, having leaders who will promote, and having scientists and physicians and other clinicians, as well as community health workers, navigators, and others who are going out into communities and listening, because I think that's clearly important, but also providing the access in multiple sites. And so what we're looking at here in Massachusetts are large sites where you can host the kinds of vaccinations that John talked about. And I'm sorry, I was going to mispronounce your last name, and that's why I stopped myself. But I think that those large vaccination sites are going to be critical for us to be able to get to populations who have hesitancy. We're also looking at mobile efforts to bring out vaccinations into communities. We were successful in doing that, as I mentioned, with testing, and we're looking at that strategy as well. And I talked about messengers, and those messengers are critically important. And so, so the community engagement strategies, the big vaccination sites are also important, and having that workforce and the training. So many similarities to the global experience, the continent's experience, and I think what's going to be important drivers of vaccinations here.
Thank you. Let me turn to another theme that's coming out from a couple of different questions. The US's refusal to participate in COVAX is just frankly an embarrassment. And I think, part of the moral catastrophe of everything. And in addition to the COVAX, there's also been discussions about intellectual property rules and, petitioning the vaccine technology to be a public good. Vanessa, could you comment on, what you might hope for given your global policy work with the new administration? Should we be signing onto COVAX in the US? How could we advocate within our own systems for our political leaders to move towards this idea of the public good, about vaccine, not just that it's the right thing to do, but it's the best thing to do for all of our health as well?
Thank you for that. And I think it's, I'm very hopeful. I think that my hope is that, there's been a lot of, in the discussion that just preceded your question, the reality is there is this capability. It's a question of political will and frankly, and power dynamics, right? Because many countries now have deep experience with vaccination with high success. And one of the things that's happened actually is that COVID has disrupted some of that, ability. And so our ability to protect sort of the investments and pieces that have already been done are vested in us being able to kind of, support stopping COVID in all settings now. And so I'm hopeful that the new administration, and I mean, they do know this, right? The question is going to be, how are they going to manage the different power dynamics that they're under? And one of the questions that came up in the side panel was the fact that countries like India and South Africa that have very strong manufacturing capabilities for vaccines and could be producing vaccines for their populations or their regions, for example, to be distributed quickly and effectively, have been under World Trade Organization rules, barred, and the US and the UK and those that have been under high influence from pharmaceutical companies have been part of that structure of barring, of barring the free licensing of this vaccine technology in all settings. And so I think that there has to be I think that this is going to be a new administration that is clearly going to want to be re-engaging in the global community. I think they will be, and they're going to, I suspect that this new incoming administration is going to want to go back to that idea of for better, for worse, and I'm the messenger on this one. I'm not saying that America should sit there and be like, we are the saviors, but the US does have a history of when it puts its mind, money, political will, and effort behind something, it can be very effective at supporting, positive programs like PEPFAR, for example. And there was a New York Times op-ed that came out 2 days ago that suggested there should be a PEPFAR for vaccine production and distribution, a very focused effort that puts money, effort to support countries to, roll out a vaccine, put the funding and the manufacturing capability for countries to be able to roll out a vaccine program. And I think that you will see an approach to that again, where people are going to say, we have to be involved. We have a obligation not only to make up for the last 4 years, but to kind of step in at this point and really support being able to produce, to have a vaccine distribution program. So I think you're going to see more of that. I think you're going to see hopefully more of a stand up against kind of these dynamics of the World Trade Organization to bend the rules and to really to get a vaccine rolled out. I don't think there's a clear strategy yet about what that looks like. I do know that Pfizer, which has obviously got one of the leading candidates for a vaccine and now has just announced it's going to up its production of the vaccine to 2 billion by the end of 2021, is actually engaging just directly in talking to COVAX. So you are starting to see some of these shifts. But I think the reality is that somebody who is hoarding the vaccines, one of these countries that, somebody's got to take a stand in this moment. I'm very hopeful and to break up some of the power dynamics. And I think this administration will do that and will take a harder stand about making equitable vaccine distribution available and working with partners around the world to make that possible. But I also think the leadership of others raising voices as we're watching the power dynamics of the world shift. And you're seeing different voices have more weight and impact. I think we're also going to see more pressure come. So as you start to see other countries sort of express frustration with what's happening in the world today, I think there's going to be more pressure to do the right thing too, if that makes sense. And so the problem that I have is just, it shouldn't take this long to get to that point, right? This should be a January 20th announcement, move, and plan in place, but it doesn't necessarily always work that way. And so my worry is it's still going to be a couple months of managing the internal politics in this country before we really step into what needs to be supported globally, and to take ourselves out of the way of being a barrier to sort of really getting some of these vaccines up and running. The problem too is that right now, AstraZeneca is sort of just coming online. Johnson & Johnson's probably a month and a half away. So some of these vaccines are going to be more readily available, are still a couple months off. And if you look at what's happening around the world in terms of numbers, you're starting to see the pandemic explode in places where, because of the very proactive and smart public health measures and other things that had happened, the pandemic was sort of, the numbers were kept a little bit lower. But that again speaks to the capability and strength of those health systems in those countries. But now the numbers globally are just so high, we've sort of hit a tipping point. And so we are racing a clock, and the moment is urgent. And so hopefully our own hubris will get out of the way, and we can do the right thing both globally as well as for everyone, I guess.
Yeah, thanks for that. So just by the way, for everyone, I know some people some of our audience probably had to leave at the top of the hour. We are going to go until 10:15 in Boston, which is 6:15 in Addis. So I'll take a couple more of the comments. Dr. Nkengasong, so Mark Seidner, who's one of our infectious disease doctors here at Mass General, is asking if you think the primary challenge to securing vaccine is the question of the funds for it, or advocacy, engagement from the right leadership, or a lack of the transparent negotiations between the suppliers and the purchasers, which we've also seen a lot about, and thinking through the potential solutions to each of these components of it.
I think that let me start at this point of thinking that across the continent of Africa, there's a general awareness and recognition that this is a terrible humanitarian health problem. It's also a terrible developmental issue in terms of the impact on economies. I mean, just like it has impacted all over the world, but at least in the developed world, you are ready to inject trillions of dollars into the economy. We cannot do that. So I think our best hope is to get the virus out of the way, and then we start doing our business, which especially recognizing that about 70% of our economy is in the informal sector. So I just wanted to start there because now the question of what is the challenge? The challenge is, so that awareness is there. I've had the chance to brief the head of states, what they call the Bureau of Head of State, 15 of them. They come together as under the guidance of President Ramaphosa, because he's the chair of the African Union. I have to brief them 12 times, including just yesterday, before President Ramaphosa make the announcement. And they listen, they take the advice from the CDC seriously, they revert back to you, and if they cannot resolve, they say, well, we really need a CDC to. So they are taking this seriously. So in other words, the money piece is really not the issue. I mean, countries, given what they know now with this pandemic, will be happy to get monies from the Afro-Exim Bank, work with the World Bank to get monies to get vaccines. The real issue is, where are the vaccines? Okay, I think as Vanessa said, I mean, countries have, richer countries mortgaged the vaccines a long time ago, and you even if you have the resources and money, you cannot, you don't know where to get it. That's why we step in with the the whole of Africa approach to secure the limited doses that we announced yesterday through President Ramaphosa as chair of the AU. So I think that is key. I mean, that is the key here, meaning that is really the availability of the vaccines. And this is not different from, permit me to borrow from our experience in diagnostics. When we as a continent were faced with this pandemic, there were no diagnostics, and it wasn't an issue of money. I mean, I remember I wrote a piece in Nature where that led Africa into the diagnostic market. It was the head of state, President Museveni. I mean, they will call me, John, we have the money. We don't know where to get the cartridges for Gene Expert. We don't know where to get So at some point, it's not about money. But the key lesson, and I'll stop here for the continent of Africa, is that for the health security, and I would like people like Vanessa and Wanda and others and you, Louise, to factor this into the advocacy piece, is that a continent cannot guarantee its health security if you don't do three things. You don't produce diagnostics, you don't produce your drugs, you don't produce vaccines. Then every talk of it, whether you do 10 JEs, the joint external evaluations, you are wasting your time. I think that is it. And I've just developed a position paper, which I'm calling a new public health order for the continent, which I'm submitting to the next summit of the head of states in February 5th, where I say, well, post-COVID, you should be thinking of three things, three major things. I didn't want a long list of things. I said, you have to be able to incentivize your own the continent to do these three things I mentioned: diagnostics, vaccines, drugs. Second, you need to beef up their workforce for public health workforce development. Again, the kind of thing Vanessa has been doing, you have to. I mean, we need 6,000 epidemiologists. We only have 1,900 on a continent of 1.2 billion people. You have to. That is just an example. And thirdly, you have to strengthen your own national and regional, national, regional, and continental and public health institution, the Africa CDC. Africa CDC is only 4 years old, but I think there's no doubt that they now know that they have their own public health agency. I mean, they meaning the head of state. It was the idea to set it up. They come to it, they debate ideas, and they get guidance and instruction. We want to see that each country develop its own national public health institute that can work in a network with Africa CDCs to guarantee the health security of the continent. That is a plea that I've put in front of them as the post-COVID recovery and what I'm calling a new public health order for the continent.
Well, your 4-year-old CDC has performed substantially, outstandingly better than our decades-old CDC. But I will tell you that we feel very lucky here at Mass General Hospital because our Chief of Infectious Diseases, Dr. Rochelle Walensky, will be taking over as the head of the US CDC on January 20th. And we're very excited about her integrity and her science-based activities. So I hope you two will be getting to know each other. Let me just in our last couple of minutes tie one question together, and then I'll go to each of the three of you to make a comment on this, if you will, and maybe just your own closing comments so we can wrap up then at 10:15 here. Questions come in about some of the technical aspects of the vaccines. So some of the vaccines seem to be having a different efficacy than the others, and that will just be the reality of the different technologies. And then we also have this discussion in the UK where they have decided to delay the second dose and potentially have a mix match dosages depending on which vaccine you get first. You might get a different one next time. How could we, and we don't know yet what the efficacy of that approach will be, how can we make sure that we don't end up with a two-tiered system, even within the vaccine accessibility, where actually the communities who most need the most effective vaccine end up with the one that's least effective or with the strategy that's least effective? So I'll pose that to each of you, if you have thoughts on it, and please feel free to give any last words as we go around. Maybe Wanda, I'll start with you, and then we'll go to John and Vanessa in that order.
So again, thank you for having me. And, I realized one of the things that I didn't mention in my own introduction is that I've had the pleasure to serve on our governor's advisory group for the equitable distribution of the vaccine. And so this question really ties in with how we approach that work. And early on, when we didn't have Pfizer, when we didn't have Moderna, one of the challenges that we grappled with is, what do you do if the vaccines that come out first are the ones that have the, are effective and safe, but have a lower efficacy than those that come later when you're prioritizing vulnerable populations to be the first. So we have talked about this issue, and I think the most important, so we have been fortunate that the two vaccines that we have similar efficacy. Our challenge is that we still have the problem of hesitancy in populations even with these two. And I do think, though, that the single dose vaccines, once those come online, will be a huge benefit to vulnerable populations. We have issues of people not being able to miss 2 days of work to come and be vaccinated. So I think that those will hopefully be more widely accepted, and hopefully, and the data is not here yet, hopefully they'll have the efficacy. I think the not having the second dose of a vaccine that requires two, to me would be an equity issue, because I do think that those who have gone first will have had both doses, have more immunity, and those coming later won't. And so I would just, from an equity perspective, I think having consistency is critically important in this regard. And again, it erodes trust when things kind of change in the middle of the game. And so I just would close with that.
Thank you. John, can we move to you for any thoughts on that?
Yes, on that question, I mean, on my closing remarks, I'll keep that very brief, is that we should continue to rely on science. We've all agreed that at the beginning of this pandemic to now that science should be guiding the response. And I want to believe that there was science behind the clinical trials that led us to the efficacy rate that we are all pronouncing for Moderna and Pfizer and AstraZeneca vaccines. So if we use science to arrive at that, and based on that, these vaccines are approved, and then in the implementation downstream, we start playing with it, then we are really in a very slippery zone there, because the whole area of vaccine hesitancy and conspiracy theories and what has become extremely sensitive, that you really don't want to mess with that, okay? Because it would not just be something that affects the COVID vaccine uptake, but the overall immunization programs in the world. And people like us and others are only alive because we have been bombarded with about 10 or 15 vaccines. Nearly any other vaccine that is out there have received it. So we don't want to compromise the future of human species because of this loss of interest in vaccines. So let's science drive it. Let's not mess with things that were done properly there. My last comment is really more global, that in terms of, to close at least my thinking on equity and access, the United States has always been a force of good, where they have exercised leadership in global health. Vanessa touched on PEPFAR. I think I worked in PEPFAR for many, many years, starting in 2003. It's perhaps in the history of infectious diseases or diseases as a whole, the greatest single most important program that one country has put out there. And without that program, I believe the continent of Africa would have been wiped out by HIV/AIDS. So that leadership from the United States has always been determinant, and other programs like the President Malaria Initiative and the Global Health Security Agenda. During the Obama administration, there were about 40 countries in Africa that were supported through the global health security agenda. It was pushed back to just a handful of about 5 to 10 countries. I mean, and now we know that global health security matters to everybody. So I'll just leave it at that. I will remain very hopeful as a continent that the new administration will embrace global health fully and brings its might and the respect that the United States has always enjoyed in that space where it shows leadership in global health and global health security issues.
Thank you. Vanessa, you get the last comment.
I have nothing to add in terms of the breaking down of doses or anything like that. I think that's exactly right, especially when we're dealing with vaccine hesitancy. I guess the one thing I would just add is that I'm an optimist, even in the worst of times. I always have been, because I think you have to be if you're going to help partner, imagine, mobilize, and help people understand that the things we've always deemed impossible are actually quite possible if we put our political will, our effort, and our imagination behind it. And I think that in this moment, it demands that kind of lean in and that deep belief that we can create change, because we know we can through all the success stories that we've just heard. It's a question of whether we're willing to. And the beauty of it is, at least from this moment, I think, is that this pandemic has shaken us up in such profound ways globally that we do have a chance to imagine, how do we do this better, right, in this new world that we live in with more connectivity, smaller world, faster travel, the fact that we are going to be vulnerable to this again. And so I remain really, really hopeful that whether it's this administration, whether it's Macron in the EU, there's going to be, or wherever it comes, or whether it's the Africa CDC and the continent and the African Union that leads this, there's the ability for us to stand up and say there's a new, better way where we all will benefit from and do better. And it's climate, it's COVID, it's a number of things. It's the gross income inequity that we see in the world today too, that has to be rectified, that underlies this. It's the racism. But I think we are at such a raw point that if the conversations are done in the right way with strong leadership and vision, and all of us coming together to really rally behind it, we will be in a place where we can help very much change how we live and the planet we live on and what's possible. And so I will be optimistic, but I think we can't be silent. I think we can't assume that's going to happen. And I think it's incumbent on every single one of us to be engaged in those conversations. But from this very difficult moment, I think we will be able to emerge somewhere better. I think we have to.
Yeah, that's really great. I mean, I appreciate us ending on a note of optimism, because I think those of us on the call and those who've joined us in the attendees are at least optimists. And maybe we can kind of close with the idea that each of us within our individual powers, whatever they might be, has an opportunity to take some action, whether that's in the institution, in this town, in the state, or in the global situation. And if we want to avoid the moral catastrophe of history judging us poorly, we have to listen back to, that quote that you mentioned, John, of the fierce urgency of now. So thank you all so much for joining us. I thought this was a really great conversation. I really appreciate you joining us late in the evening there in Addis. Thank you, Dr. Nkengasong. Thank you for your leadership of the Africa CDC. Ms. McClain, thank you so much for all you do locally, and Vanessa for your work on this locally here and in Africa and on policy. Thanks for all the attendees. We're going to post our video on our YouTube channel. Thanks very much. Have a good rest of the day, everyone.